when women come to me, they're like, I'm afraid of estrogen. And I say, why? Why are you afraid of estrogen? Because I just want to know, like, where are they getting this from, right? They don't know why they're afraid. They've just heard from somebody that estrogen's bad. The number one killer of women who've survived breast cancer is heart disease. The number one killer of men who have prostate cancer is heart disease, right? So they're like, estrogen helps the heart. Estrogen helps me sleep. Estrogen helps my bones. Estrogen helps the brain utilize glucose. You take the estrogen away, the brain's failing at metabolism.
Dr. Kelly Casperson is a urologist,
author, and podcast host
on a mission to empower women with real science about
hormones, menopause, and sexual health.
Is testosterone being prescribed to women off-label?
Yeah, there's no FDA-approved indication.
Yeah.
So by definition, it's all off-label.
Wow. But like women are getting this and they're seeing benefits.
Yeah. And another big myth is like, yeah, but you're making testosterone just to convert it to estrogen. No, we have testosterone receptors everywhere, and we make 4 times the amount, and it doesn't all convert to estrogen. But we gender bias to these hormones. Like, men don't know they have estradiol, right? And men have more estradiol than postmenopausal women do.
Dr. Kelly Casperson, welcome to the show at long last.
Thanks for having me.
Thanks for coming out. We've been friends for a bit on the socials because I've somehow become an unofficial member of the manosphere.
Well,
I've heard.
Yeah, so you came on my podcast after I invited you because you said something, I don't know what you said on social, but it was something like very pro-female hormone.
I'm pro-female hormone, yeah.
And I was like, we need advocates, we need people who understand this. And then your mom's story with your documentary. So I was like, you need to come on my podcast.
You're the best. I remember what I said. It was something like, it's a crime that women have been basically withheld this potentially life-changing and ultimately life-saving, in many cases, treatment for so many years due to misinformation.
I think it's more powerful when it comes from a man, like sadly or not sadly, just truthfully. Like when men say that, there's weight to it because it's like, it's not your body. You don't have this experience, but you're seeing what's happening to these people and you're like sticking up for them. And if a woman's like, hey, this isn't great, people are like, well, she's kind of complaining. So like, I think the male perspective is super powerful every time people, like Peter Attia saying it is like, nobody disagrees with him when he says it. And so we're like, we just need more voices saying, what are we doing to these people at this point when we have so much data?
Why are women so routinely gaslit when it comes to their own health?
I think in the physician world, and I get to say this because I went through the training, like you're in it, so you're able to say it, is like we weren't trained how to take care of women. Like it's a male model, and especially now when it needs to be fast, right? And this stuff's complicated. Like it's biopsychosocial, it's your brain, it's your ovaries, it's everything. It's like it takes time, and the system's not set up for that. So like dismiss them, give them a prescription, tell them it's all in their head. Like these are easy tactics to get them out of the office. And no physician wants to behave like that. Like we ultimately care, but the system's not built to take care of people that we don't have a lot of research on them.
And also, like, I mean, in all fairness, women are way more complex than men. We're just like simple.
Yeah.
We are like
men are Hondas.
We're
like, good resale value, very trusty coffee mug holders. But like women are like, we create life. It's insane. Like we are the Ferrari, but it's as if being a Ferrari is a flaw instead of like the complex machine that it is. Because even saying like women are more complicated is very dismissive, right? Like we don't have time for that. That might take more time and money. Let's dismiss it. Instead of like, they're the Ferraris, let's realize what we don't know and let's try to keep them running.
Amen. Yeah, I mean, the monthly cycle, like, pre-menopause, it's like, I would think that as a clinician, it's like when you're getting labs and you're getting like this like thin slice during this cycle where so many things are moving, it could feel almost like shooting a moving target.
Yeah.
Am I right?
It is a moving target.
Yeah, it's like that. It's like the camera on that slider over there. Kind of.
Yeah, it works mostly, but when it doesn't, like there's a lot of different things to figure out.
Exactly.
I mean, the other thing with like periods is like it's more difficult to study because if you want to study something, you only want one variable, right? And you're like, with monthly cycles, there's multiple variables. So if you're going to put women in a study, you need them all to not be ovulating or be on a certain day, and like that takes more money. And so it does come down to economics sometimes on like studying these bodies is more expensive. Doesn't mean we shouldn't, but it's when people are like, why isn't there more research? It's like, well, might be a little more expensive.
Well, we love women here on this podcast. We've got a wonderful audience of females that listen, as well as the men who love them. And so I'm excited to have you in to talk about a topic that I think is still under discussed. I mean, we've done a number of episodes with Suzanne Gilbert-Lenz and others talking about the topic of menopause, but you've got this incredible book out, and yeah, I'm excited to pick your brain about all the things. But let's just dive right in. So what would you say are the biggest myths that women are still being told about hormones and midlife?
That they don't matter. Perimenopause isn't real. That living 40 years post-menopause is natural, right? Like, it's just myth after myth after myth. Like, that sex is supposed to be painful. That, like, the suffering is supposed to be tolerable. And the myth of natural is actually very interesting, and I researched it for the book, because so many women are told, like, it's just natural. Like, just deal with it. And it's like, we treat everything else that's natural. Like, if you fall and break your ankle, I'm not like, Max, that's natural. Like, deal. You're like, I'd like to see if I can put the bone back in the leg. Like, surgery's good, right? And so the myth of natural falls away so quickly. Like, if you need glasses, I don't tell you it's natural to not see well, or hearing aids, or teeth, or a hip, or a heart valve. Like, we treat all these naturally aging things in healthcare, but with ovaries, we're like, hold on, that's natural. Do that one without support. Like, it just makes no sense. And the myth of natural is actually this like philosophical belief that if it exists in nature, it's therefore superior. And so I think it comes into this like purity culture for women, this perfectionist culture for women, this like be as close to the nature as you can for women of like, it's a really great way to like silence them, keep them down, keep them suffering, and it works. So I love busting the myth of natural all the time for people, because you're like, oh, flossing isn't natural, right? Like, it falls away so quickly.
I love that. And it's, I love that we're going there, because, I mean, I think that there are some contexts in which an appeal to nature might be reasonable, but then I think that there are others when it's totally unreasonable. Like, if you've got a headache, take a medicine for it. I mean, I have a prosthetic L5S1 disc.
Right.
You know, if I just were trying to avoid all things unnatural, I mean, I wouldn't have gone through with this life-changing surgery for myself.
Yeah.
So this idea that we can replace hormones that would otherwise recede at a certain point in our lives, and in so doing dramatically improve quality of life.
And I think
potentially help avert awful diseases like Alzheimer's disease, which we're going to talk about. Very exciting.
Yeah, I mean, I think, you know, everybody agrees menopause is natural at a certain point. Ovaries are only so big, and the size of an ovary is dependent upon the size of the mammal, right? So an elephant's ovary is bigger than a human's ovary. And how big it is how many follicles it has, and follicles make hormones. So if this machine runs for a while, eventually it's just going to run out of follicles, right? It's not because nature told it to, or it's holy or anything like that. And us living to an average age of 84 as a society, one could argue, is not natural, right? Antibiotics alone extend the average American's lifespan by 26 years. And so you're like, dude, we've done everything, clean water, sanitation, right? A supply of food. So it's like we're living 40 years past the natural exhaustion of an ovary. And here we are saying, well, yeah, let's live that long and let's do everything to live that long, but let's not replace this one organ, but we'll replace your heart valve, we'll replace your shoulder, we'll replace your teeth, we'll replace your eyes, we'll replace everything else. Like, it's insanity when you start thinking of it like that.
But why were so many women so afraid of HRT for so many years?
Yeah. So in 2002, the Women's Health Initiative, we call it the WHI, was a massive study, federally funded, to answer a very specific question. The specific question was, if we give women hormones, will we decrease the risk of heart disease? They already knew the answer was yes, but they didn't have a randomized placebo-controlled trial, which is considered the gold standard, right? But cardiologists, if you look at the literature in the 90s, the cardiologists were like, this is great. They have less heart disease. They have less heart failure. They have lower blood pressure, all of these things. But let's prove it. So they did this massive study enrolling older women who had minimal symptoms, average age 63, average age of menopause 50, 51, right? So older women didn't have symptoms, and they stopped it prematurely. The crazy thing about this study is it's free online right now. Like, you can go read this study right now. And if you were to pull it up and you were to read it, which is the 2002 Women's Health Initiative, it says, basically got close to statistical significance for increased risk of breast cancer. Which, if you're a scientist, you know, if it didn't reach a statistical significance, then it wasn't statistically significant. We don't care if it got close. That's not science, right? So the paper is free online, but back in 2002, there was no internet. There was no email. As a physician, I would get that paper in the mail a week after it got released, right? So they went to the press first which again is a big no-no. Like, publish it so people can read it before you go to the press. But they didn't. So the press got a hold of it. The press basically blew up, said this causes breast cancer, probably causes heart disease. People were like flushing their hormones down the toilet. The doctors got the paper a week later, and there's no social media. There's no no podcasts, right? No emails. So there's no way to like put the genie back into the bottle. And they said, if you go to the press and say this, a genie will leave the bottle, we'll never be able to get it back in. And here we are 23 years later. We are still like struggling to put the genie back in the bottle of hormones are safe. The breast cancer incidence did not reach statistical significance. And furthermore, in the estrogen alone arm, they had a decreased risk of breast cancer. So it was actually opposite of what the media said.
Wow.
Yeah, it's absolutely crazy. Like we're talking to investigative journalists of like, does anybody want to do this story? Like, this is a massive story, and it like needs to be shared in like a way that people will finally like bury the coffin.
Wow. Imagine that, the mainstream media spreading misinformation.
Yeah, right? It's been going on for a while.
What a concept.
This is not new. Yeah.
Insane. So it did irreparable harm to the public image of this therapy.
Yeah. And so the doctors who got the journal a week later and read it said, this is not actually that bad. And those physicians kept their women on hormones. So there is a small section of women who've stayed on hormones for 20 years. They're now 84, right? And if you talk to them, you can be like, you know, what do you want? And they're like, we'll never stop these hormones. Like, they got through. But a good 60 to 80% of women didn't. Because, you know, most doctors aren't reading journal papers and like critically evaluating it. But back, you know, when people ask me, they're like, how happy are you going to be? How many women need to be on hormones for you to be happy? Blah, blah, blah. And I'm like, I'm not here to tell women to go on hormones. I'm here that they get accurate information and they know how to advocate. Then they decide what they want to do. Women are smart. They can figure things out. I'm not here to tell them how to live their life. Like, and I don't care. Like, that's their body, not mine. But in the 1990s, before the WHI, 40% of American women were on hormones. Now it's about 5%. So I'm like, can we just get back to the 90s? Like, there was a time when a lot of women were on hormones because they're safe and they're effective.
When did that therapy start being administered? Like, I didn't realize that
40s.
In the 40s.
In the 40s. So, like, testosterone and estrogen are called sex hormones because they were discovered in, like, turkey testicles and bull ovaries, right? Like, animal gonads, basically. And so they were like, hey, if you give this to somebody, it develops their sex characteristics. So they were labeled as sex hormones. I think to this day, that's a mislabeling because they're neurohormones. They're in your bone. They help your muscle. They help your heart, right? I can't say sex on Instagram.
Crazy.
Right. So we finally got fed up and I'm like, I'm sick of not being able to say sex on Instagram. Let's rename these hormones. So we had like a Zoom meeting with like 23 menopause experts. We're like, what should we call these things? Right? Because sex seems like extra to people. Like, you're not reproducing. Do you need these things? We're like, can we call them neurohormones? What should we call them? So we kind of call them PET therapy now, which is progesterone, estrogen, testosterone.
PET therapy.
PET therapy, or precision endocrine therapy is also the same acronym. But so we're kind of like taking that on. It's easier to say on Instagram because Instagram has a sex bias. So they were starting to give extracts of this back in the 40s. They were starting to give testosterone to women in the 40s because women were suffering and they wanted solutions. And then the pharmaceutical companies started really with synthetic ones. The newer bioidentical, which is exactly what your body makes, that's kind of newer formulation. But we've been giving women synthetic hormones for 80 years at this point.
Wow. I mean, it kind of dovetails with the story that I'm somewhat more familiar with regarding very interesting and might sound tangential but related, BPA. Bisphenol A, which is a well-known endocrine disruptor, laces, hardens plastic, saturates our store register receipts, was originally designed to be an estrogen replacement.
Interesting.
Yeah.
I didn't know that.
Yeah, BPA.
Now it's on receipts.
And now it's on receipts. Yeah. They realized that it was originally designated to be an estrogen replacement, and they realized that it could be used to create plastic. And then that's probably around the same time, I'm guessing, that they came up with they were like, synthetic is probably not the ideal path.
Yeah. It's super interesting because, we were talking earlier of like why, if bioidentical hormones now are proving so beneficial, why aren't they having Super Bowl ads, right? Like the big blockbuster drugs that have Super Bowl ads. It's like because they're not brandable, they're not patentable, they're generic, naturally occurring molecules. They're very hard to make a ton of money on a unique, patentable way. And so I think that's another reason of like, it's people aren't learning about it unless they're learning about podcasts like this, because you're not going to see it on Super Bowl. Like there's no Super Bowl ad that says this probably might reduce your risk of dementia by 20 to 30%.
Damn. All right, so this harm was done to the public image of this this therapy, these hormone replacement, and now experts such as yourself, you're really like putting in the legwork, trying to basically unwind all of that misinformation.
Yeah. I mean, my story is unique because I'm a urologist, right? So a urologist is a special surgeon who does the genital urinary tract. So kidney stones to prostate cancer to bladder cancer to testicle surgery, right? We're really the genital urinary system.
Do you work with men and women?
Yeah. And that's what gave me kind of my social media superpower in one way, because unlike the gynecologists, I take care of all genders, right? So I've got this group of people and we're like, oh, you have trouble with your sex life and your hormones? Let's give you testosterone and Viagra. And this group of people is told, like, getting old is natural and maybe, have a glass of wine and, like, find an acupuncturist, right? And so I'm like, same problems, different people, different treatment and medicine. And that, like, gender bias, because it was so profound in my practice, I'm able to kind of speak that. Whereas the gynecologists don't know what we tell men, right? And with men, we're like, dude, that's a problem. It's a problem if your erections don't work, and it's a problem if you don't want to get out of the couch. Right? And for women, they're like, I don't feel like myself and sex hurts. And we're like, oh, well, try some lube. Like women are told horrific things to try to make their sex life better. And so I got into it because of genital urinary syndrome of menopause, which hormones are everywhere. They are in your brain, they're in your bones, they're in your muscle, they're everywhere. And they help your bladder, they help your clitoris, they help your labia, they help your genitals, they help your vagina. And when your hormones go down, all those things start to function less well. And so women come to me with recurrent urinary tract infections, overactive bladder, getting up at night to pee, pain with sexual penetration. And I'm like, vaginal estrogen's like God's elixir. It's like the best essential oil. Like, give it back to your pelvis, right? But they're like, I'm afraid of estrogen. And furthermore, the black box warning on it that the FDA slapped on all estrogen products after the WHI is so incorrect, it's laughable at this point. But a friend published a study that if a woman's lucky enough to get a vaginal estrogen prescription, and she goes home and she opens up the boxed warning from the FDA, and it says probable dementia, blood clot, liver disease, heart disease, she's not going to use it. About 30% of women will not use it, even if they're lucky enough to get it, and all of that product labeling is wrong. So we went to the FDA in July to talk to them about it.
Wow. Marty McCary seems like he would be totally on board with.
He's completely on board with it.
That's amazing.
Yeah.
Yeah. Shout out to Marty McCary, who's a past Genius Life podcast guest now, heads up the FDA.
Yeah. Pretty awesome.
Pretty awesome. Wow. So many questions. Okay. So topical vaginal estrogen, you're saying, is like pretty benign, very beneficial.
It's skincare.
Skincare.
Yeah.
Amazing. Now, is that the kind of thing that you feel comfortable in saying, like, all women past a certain age should be on it?
Yeah. Yeah. So vaginal estrogen in many countries is over the counter. Like that, just to tell people how safe it is, right? And it's skincare. And what I mean by that is dosing, right? People are like, what's the difference between an estrogen patch and vaginal estrogen? Why does one get in your body and one just stays on the skin? Dosing. It's like the difference between a shot of whiskey and like a bottle of whiskey, right? Dosing. So vaginal estrogen is very, very low dose. You basically have to use like an entire year of it for it to count as like one estradiol pill that you would swallow. So skincare, low dose, doesn't get into your body, incredibly safe, even for cancer survivors. And it's just like the fear, estrogen, right? Like the word, we've made women afraid of something their body naturally makes, which is insane. And so a lot of this is just boots on the ground education. And, when women come to me, they're like, oh, I'm afraid of estrogen. And I say, why? Why are you afraid of estrogen? Because I just want to know, like, where are they getting this from, right? And it's kind of in, like, the zeitgeist. It's, like, in the ether at this point of, like, they don't know why they're afraid. They've just heard from somebody that estrogen's bad. And it's like, we have to do all this education because you can't just come in and be like, vaginal estrogen for the win if people are like, doesn't that cause cancer? So you have to go back and dig out the WHI to educate people.
Yeah. Now, if somebody's on oral systemic estrogen, do you also recommend that they're also on the topical vaginal estrogen
They can be. And I use a simple math equation for that. I'm like, if systemic estrogen, whether that's a patch or a pill, increases your estrogen level to X, vaginal estrogen skincare, so it increases your estrogen level to 0, X plus 0 is X. Very simple. And about 30 to 50% of people because the systemic estrogen doesn't give you like 18-year-old estrogen levels. Like it doesn't give you pregnancy estrogen levels, like insanely high estrogen levels, right? Like this is giving you like good enough estrogen levels. It's still very, very low dose. And so to go into the like where the preventative medicine comes in, because I still think we're years away from like systemic as prevention as a society. Side note, like if you're an individual, you can choose that. But for vaginal estrogen, we know 50 to 80% of women will experience genital urinary syndrome of menopause. So dryness, pain, recurrent UTI, bladder leakage, all that stuff. Incredibly common. If we treat them with vaginal estrogen, which decreases your risk of urinary tract infections by 50%.
Wow.
It's nothing else works better. So for people who have elderly mothers or elderly aunts and they just see these recurrent UTIs, like get them on vaginal estrogen. So we don't say, oh, great, your UTIs went away. Let's stop the vaginal estrogen. We continue it as a preventative medicine. So we're already using it as preventative medicine. Now, where people really raise their eyebrows is they're like, wait, hold on. Labia minora and clitoris go away and shrink when your hormones go away. We're like, yes. And they're like, well, why don't we just try to keep those in the first place instead of like wait for them to go away and then try to get them back, which we have very little data on. Like, can we get labia minora to come back with enough hormones? So it really kind of pushes the like, why wait for women to suffer? If this is just skincare, why can't we just start it at some point and say, I would like to not get the UTIs. I would like to not get the pain with sex. I would like to not wake up in the middle of the night to urinate, right? So I think vaginal estrogen is way ahead of systemic estrogen as far as preventative medicine is going.
That's crazy that the withdrawal of these hormones would cause those tissues to atrophy. That's so odd.
It's what made them adult tissues in the first place.
Huh.
Right?
Right. Yeah.
So if you look at a baby, they don't have a labia minora, they don't have well-developed external genitalia. People go through puberty, and then you have adult genitalia. Then it goes away when you lose your hormones.
That's so interesting. So when we say HRT, is vaginal estrogen considered HRT or no?
I mean, I think going back to like why we're trying to relabel it pet therapy is like HRT for a lot of people means like oral, synthetic, or just estrogen. Like everybody's got their label of what it means.
Yeah.
And so that's why we're kind of like, oh, let's call it pet therapy or precision endocrine therapy, because there's so much stigma, even with the WHI and HRT, right?
Yeah.
So we're like, let's just call them what they are. But by and large, yeah, I mean, it's HRT. You're putting hormones back in the pelvis.
Got it. So systemic PET or HRT, that is progesterone, estrone, testosterone traditionally, or because I know you're a big advocate.
Traditionally, it's estrogen.
Just estrogen.
Plus or minus progesterone. And that the myth is only if you have a uterus, right? People are like, only if you have a uterus do you need progesterone. And where that came from is, again, the WHI was a synthetic progestin. And if there was any bad guy in that study, it was probably the synthetic progestin. Now, most of us will say if we were on a deserted island and we had one pharmaceutical option and that was the WHI meds are all we had, we would probably still take them. Because at the end of the day, with the data, they weren't that bad when left with like that versus nothing. But that synthetic progestin is why people are like, you don't need progesterone or you can't have it. That's where like only if you have a uterus came in. But progesterone gets converted to GABA, which goes into our brain and helps us with sleep and mood. And so it's like you don't need a uterus to say you can have or not have progesterone. There's actually data in men for sleep with progesterone.
Interesting.
Yeah. So progesterone is like a nice, all the hormones have their like stereotypes, and progesterone's like the mellow sleep one. Most people can tolerate the oral micronized progesterone, and it's generic. Like this stuff's cheap. And about 60% of women have sleep troubles in perimenopause and beyond. So it's like the whole myth that you can't have it if you don't have a uterus is kind of going away.
Got it. So any woman who's interested in PET or HRT, can we use the terms?
You can do it, everyone.
Okay,
yeah.
I
I use them interchangeably, but I think the HRT has a stereotype, so it's nice to...
Yeah, to shed that.
To shed it.
Yeah. Okay, so PET, aka HRT, but we'll just say PET. Should women inquire with their physicians about all three of these hormones?
Well, your ovary makes all three. I mean, that's kind of the question of like, why not?
Yeah.
Right? Like, if your ovary slows the production of all three of them, why not? I think a lot of people don't know that ovaries make 4 times the amount of testosterone than estrogen. And another big myth is like, yeah, but you're making testosterone just to convert it to estrogen. It's like, no, we have testosterone receptors everywhere, and we make 4 times the amount, and it doesn't all convert to estrogen. So we make testosterone, we use testosterone, but we gender bias to these hormones. Like men don't know they have estradiol, right? And men have more estradiol than postmenopausal women do. People don't know that, right? And so it's like ovaries make testosterone. Ovaries slowly decline in testosterone after our 20s, right? So it's like a slow linear decline. There's nothing magical about a last period. There's nothing magical about like the day of menopause with testosterone. And testosterone is going to be FDA approved for female use, hopefully within 3 to 4 years at this point. Companies have gone up to the FDA before. Unfortunately, the last one was like right after the WHI. So again, big fear and stigma of hormones. So it's been about 20 years since a company's gone up for a female dose testosterone, but they're doing it again. There is a need. And it's hard to measure this in America because a lot of women get their hormones compounded. So it's hard to measure them, like they're not in insurance databases. But the experts think as many women currently are on testosterone in America as men are.
Wow.
Yeah.
But is testosterone being prescribed to women off-label?
Yeah, there's no FDA-approved indication.
Yeah.
So by definition, it's all off-label.
Wow.
Yeah.
But like women are getting this and they're seeing benefits.
Yeah.
That's so cool.
Otherwise, they wouldn't continue to use it.
Yeah.
And they wouldn't tell their friends, right? But we've been giving testosterone to women since the 1940s. Like the gynecologists they were treating like menstrual disorders and like uterine bleeding. So there's a lot of data, but it's old data because nobody was researching hormones after the WHI. Like we have this 20-year iron curtain.
Now, at what point should women begin to have this conversation, start having this conversation with their healthcare providers?
Yeah. So average age of menopause, 50, 51. Perimenopause, there's multiple definitions of the research and stuff, but within a decade, right? So, okay, average age is 51, and people think like, oh, well, then 48's too young. It's like, no, that means 50% of people have gone through menopause at 51. That's what the average means, right? So that's average. 10 years before, that's 40. And if some people go into menopause, because 50% of people go into menopause before 50, this could be in your mid-30s. There aren't great tests right now for perimenopause. It's a clinical diagnosis, but lots of things are clinical diagnoses. You tell me you have dry eyes, I don't say, well, I can't prove that because I don't have a test for that, right? It's like there's lots of things that are clinical diagnoses, and perimenopause is a clinical diagnosis. So it means it's signs and symptoms in the right age range. But the thing with women in medicine I've found is they either get told you're too young for this or you're too old for this. And I'm like, there's this magical one day that it's perfect to go in to the doctor because you're the right age for this. But often women are told they're too young or they're too old.
Wow. Now, is there a benefit to starting earlier? Because before we got rolling, you actually sent me this brand new study that just came out. It was a meta-analysis of both observational studies and RCTs that found that women who started hormone replacement therapy early in menopause within 5 years had a 32% lower risk of developing Alzheimer's disease, which is very exciting.
That's huge, right? It's massive.
Massive.
If there was a blockbuster drug that just came out that said we lower Alzheimer's disease by 30%, there would be a Super Bowl ad. Like, that's phenomenal.
But the study found that it wasn't as effective in terms of a risk reduction taken later.
Yeah. So that's the timing hypothesis, right? So the timing hypothesis, which is well published, basically they discovered this in monkeys and they said, okay, your body changes as a result of not having hormones, right? It's aging and it's aging without hormones. So the timing hypothesis says, get the hormones on board before you get this big aged period where it's been going on without hormones. So that's the timing hypothesis, is the earlier the better, because hormones are better at preventing disease. They're not so good at treating disease. And, I say, like, on that tragic, horrible day that we get diagnosed with Alzheimer's disease or a loved one gets diagnosed with Alzheimer's disease, the pathology has been happening for 20 years, right? And that's why we have to move. That's why cures are bad and treatments are bad. Is like, we had to start way back here, right? Estrogen is the secret sauce of, like, starting back here to prevent up there. And again, the haters, for lack of a better term, will say, like, well, we don't have a randomized placebo-controlled trial showing that this will absolutely decrease your risk of Alzheimer's disease. Like, that would be a 20-year study. If it's true today, when I got diagnosed, it started 20 years ago, right? So a huge lag time bias, billions of dollars of a study. It's not going to happen. we have to use the data that we have, which is what these papers are trying to do. And that's what Lisa Mosconi published a paper about 2 years ago saying the exact same thing. The younger you start, the more likely you are that when you're 72, you're not going to be diagnosed. There was a paper, so one of the women who was at the FDA with me, her name is Dr. Robbie Brinton, PhD, and she published a study, like 2019. It's a massive Humana insurance database study. It's a brilliant paper. Basically, she just looked at upwards of 1 million women and said, hey, of all these women, who's taking hormones and who's got a neurologic diagnosis, right? To try to draw some conclusions. Because again, we're not going to have randomized controlled trials looking at all of these. But the women on estrogen, decreased risk of Alzheimer's dementia, non-Alzheimer's dementia, multiple sclerosis, Parkinson's disease, and ALS or Lou Gehrig's disease. So all neurologic disorders studied decreased risk by being on estrogen. And I'm like, this is a massively important paper. Nobody knows about it. So she got to speak at the FDA, basically saying estrogen helps the brain utilize glucose. You take the estrogen away, the brain's failing at metabolism. And you know how important metabolism is for healing and function and, basically not like jamming the cogs, right? So to me, I'm like, your paper was so important and nobody knows about this, right? But if you ask women, you're like, hey, if you'd like to prevent something, wouldn't that be better than trying to treat it? Like, treating's expensive. These are generic medications, but what it requires is a woman who's 50 years old to say, how do I want to be living when I'm 75? And what do I want to do now to get me to be that person? It's like, you just sleep, maybe don't drink alcohol, lifting weights is good, have a good diet, and consider hormones for prevention. But I would say, like, we are never, as a nation, I believe right now, nobody's going to stick their neck out and say all women should. That ship has sailed. Nobody's going to say it. It's too big of an ask. We don't tell people to go on aspirin. We don't tell everybody should go on a statin. We don't say everybody should. And I think so many people are like holding their breath to be like, well, we should say everybody should. It's like, that's a big stick or a big bar to have. So I think as an individual, go get evaluated for risks and benefits, and you should have a choice to take a preventative medication if you want to. But there's not going to be a national society that's going to come out to say all women should. It's too big of an ask, like from a medical culture speaking way.
It's very different, though, to me than like statins, for example. I mean, this is like a quality of life thing. This is all women go through menopause, right?
Yep.
And we're living longer and hopefully even longer in the future than we are today.
Yeah.
And so, yeah, I think it's
a culture.
crucial.
I mean, I am a surgeon who takes out testicles for testicle cancer. It is malpractice to remove a man's testicles and not give him testosterone. Like, it's unheard of that you would ever do that. In the UK, because that's better data than America, they just did a study and they said of all the women who have their ovaries removed, so now we're talking early menopause or surgical menopause, how many of them have their hormones replaced when their ovaries are surgically removed and put in a bucket? 5%.
Wow.
So it's like, we need if it's unthinkable to take a man's testicles and not give him testosterone back, but women get their ovaries taken out and only 5% get their hormones taken back. Again, it's like, do we know what we're doing to the other gender? Because this is not equal.
Yeah.
And early menopause, so surgical menopause, early menopause, we know associated with dementia, associated with heart disease. It is hard and fast guidelines now that you should be on hormones until natural age of menopause. Nobody's arguing that. So it's like, those women absolutely should be on. After age 50, it's now your choice. But what's going to happen is the educated women who can advocate, they're choosing hormones. And so we're going to see this health disparity because not everybody can have the time to be educated and advocate, right?
Yeah, unfortunately.
Yeah.
So you see increased risk of early onset dementia in women who've been surgically or have experienced surgical menopause?
Early surgical, so surgical menopause before age 50.
Yeah.
And not just dementia, but all-cause mortality.
Wow.
Yeah. I mean, I always say if there was a medication that men could take between the ages of 50 and 60 and it increased their life expectancy by 2 to 3 years, don't you think they'd all be on it? Mm-hmm. It's called estrogen for women. Like, we have that data.
Yeah, I don't know why there are the so-called haters, because when you look at, for example, the routinely published modifiable risk factors for Alzheimer's disease, I mean, these are all risk factors. These are all correlates to increased risk for Alzheimer's, but we don't have the RCTs to show that, I mean, just last year, they put high LDL cholesterol was a newly minted modifiable risk factor for Alzheimer's disease. But we don't actually know that high LDL, we know that it's correlated to increased risk, but high LDL could be correlated to somebody eating a standard American diet and living a sedentary lifestyle.
Yeah, and I think a lot of people...
it was published and touted and, as this really important finding.
Yeah, a lot of people people don't understand like causation and correlation, and that just because it's a risk factor doesn't mean all people are going to get it. And just, I'll share something on Instagram and they'll be like, but my grandma drank and didn't get Alzheimer's, or my grandma drank and, or like my grandma was on hormones and did. And it's like, this doesn't mean everybody. But 30% is a huge decrease. Like we're winning when we can get like a 3% decrease in something, right? 30% is profound, and people don't know that.
Now, is there a population of women for whom it is a riskier proposition than others, like women who've, maybe a history of hormone-sensitive breast cancers, things like that?
Yeah, so hormone-sensitive breast cancer, we know they can be on vaginal estrogen. Multiple studies, meta-analyses. The oncology community who knows, no, vaginal estrogen is okay, and they're being inappropriately denied that medication. So again, skincare, low dose. If I were to draw your labs, I couldn't tell that you were on vaginal estrogen. That's skincare. They should be allowed. And that's the big thing. Like, we know that data. We just need to get it out to the women so they can advocate and out. But more and more gynecologists are like, yes, it's important. But this is a horror story. I just heard a couple weeks ago at a major cancer center on the East Coast, a woman came in complaining of her sex life afterwards, and the doctor told her to use Crisco.
Crisco?
Crisco, which we don't want people to even bake with anymore.
Right.
Yeah, so like that's a horror story, right? So we just need to get the word out more and more and more of like vaginal estrogen safe in nearly everybody. There's a very rare type of uterine cancer. Like this is my asterisk, right? Very rare type of uterine cancer. If that was you, your oncologist, like so rare, it's like case studies. But universally, when people on the internet say everybody can use vaginal estrogen, we're rounding up to 100. It's mostly right. Now, as far as systemic hormone therapy, we don't have a lot of data. Best book to read on this is Estrogen Matters by Avram Blooming and Carol Tavers. They go into all the data. It's basically the Stockholm trial and what's the other one? Habits trial and Stockholm trial are the two randomized controlled trials looking at breast cancer recurrence after systemic hormone therapy. One of them was stopped early because of increased risk, but again, but it was right after the WHI, so everybody was freaked out. Had it continued, would that increased risk have gone away? Stockholm trial showed no increased risk of breast cancer recurrence or mortality after systemic hormones. So they do a very good job of breaking down all the data, and they're like, we don't have that much data to say it increases your risks statistically, but it's the fear. And again, people, I say hormones help the body function. Monsters like food. If you have a monster in your body, you have to take away the food, right? So if you have breast cancer, you take away the hormones. If you have prostate cancer, you take away the hormones. That doesn't mean food caused monsters. Right. And I think that's the education. When we call it estrogen sensitive breast cancer, people think estrogen caused the cancer. No, but the monster eats the food. Right. We don't call prostate cancer testosterone driven prostate cancer. We could. They've got testosterone receptors on there, but we don't label it that. Right. We don't make men afraid of something their body naturally makes. We make women afraid of something their body naturally makes.
Totally.
So the data right now, again, it's tough because there's a lot of compounded hormones going on. But there's probably a very good, depending upon the data, people think a minority still, but a decent amount of women post breast cancer are on hormones. And it's an individual risk-benefit conversation with your doctor, what's bothering you. But the number one killer of women who've survived breast cancer is heart disease. The number one killer of men who have prostate cancer and cured is heart disease, right? So they're like, estrogen helps the heart. Estrogen helps me sleep. Estrogen helps my bones, right? So it's like, hey, we've cured you from this. We can't tell you that there's any cancer left. You should now be able to make the decision you want with your body, your choice. And these women are being denied their body, their choice with what they want to do to be healthy afterwards. So I think there's going to be a big move in the next 5 years with this, because the breast cancer population, this is 5 million women in America alone. It's a big group, and they're suffering. So we just talk and say, it's an individual risk benefit. The other like evil thing about breast cancer, which makes this conversation difficult, is a lot of estrogen receptor positive breast cancer comes back really late. after 5 years, right? And so you're like, if we give you something now, because there's no cancer here, and again, a correlation doesn't equal causation, but like that awful cancer comes back so late that people are afraid to start something because they don't, it's like so far away. And then did your estrogen cause your cancer? And because brains want to blame something, even when a lot of cancer, we can't blame anything for it, right?
Yeah.
So it's a tricky business for sure. But what we know is a lot of women are suffering, and we do think a lot of women should be able to make a decision for their body with the data we have, which says, you know what, there's a risk, but we don't really know. It's actually poorly studied, which is kind of embarrassing because it's a common cancer.
Yeah. Wild. What does the dosing look like? I mean, is this something that's injected? Is it like oral? Does a woman, I'm guessing the answer is yes, but is a woman to be on the treatment for the rest of her life once they start?
Yeah. So I always tell women, when you outlive your ovaries, women are like, do I have to take this forever? And I'm like, are you getting an ovarian transplant? Like, it's not coming back, right? When you wear glasses, do you have to wear your glasses forever? Yes. Like, there's right, it's forever. You're replacing the hormones that your ovary used to make. So yes, it is lifelong, just like flossing is. But, the weird thing is, like, you're trying to prevent disease, right? You can't decide once I have the disease, I want hormones now. Like, you actually really have to do something for the long term that's going to benefit you for something you might not ever have, right? Like, I'll die not knowing, would I have had heart disease if I had not started hormones? So systemic estrogen, oral, patch. There's a vaginal ring, actually, that has a high enough dose that's systemic, more rarely injectable. Gels, sprays. There's lots of different ways to get it. Testosterone, most commonly transdermal. We either use the male dose and microdose it, or you can compound it. Pellets are a higher dose, which pellets are polarizing. They help a lot of people, but a lot of people, they're just the highest dose. So I'm like, they're the most expensive, highest dose, most invasive, not my go-to, but some people do require higher dosing. But again, testosterone, nothing is currently FDA approved. So there's no indication for it. The most studied indication is for libido. And what drives me nuts is when people are like, testosterone's only for libido for women. And I'm like, what's libido? Libido's a mood. Libido's a motivation. This is a brain neurohormone. And if you go back to the dementia study, we know that men with low testosterone have a higher risk of both depression and dementia, which begs the question, why aren't we screening men, right? Why aren't all 40 or 45-year-old men getting their testosterone checked? A lot of the experts think they should be, right? Because it's like, we don't know when your testosterone's low, especially if you don't have symptoms, but it's associated with bad outcomes. So there's a cadaver study looking at both male and female brains, and the brains that had higher testosterone had a lower risk of dementia. And if you look at the way testosterone works, right, it helps nerves heal, it helps glial cells, it helps myelin sheaths, like this helps nerves function. And so we use the male data, we use cadaver studies, we use how nerves work, we use mitochondria to be like, testosterone's probably a dementia preventing hormone also. But it's like, God, we don't even have an FDA-approved indication for anything, let alone prevention.
Yeah, we got to get rid of the stigma. I mean, I have friends who are my age and some even younger that are currently on TRT, and they love it. They're like never coming off it.
Yeah, it's a quality of life thing.
They go on it, and like suddenly every post on Instagram is them shirtless.
Might cause sudden loss of clothing.
Yeah, exactly. It's crazy. Very interesting stuff. Yeah, I wish it was something that my mom had considered, because she was very afraid. I mean, she was afraid of, I don't remember if she was afraid necessarily of the breast cancer side of things or probably the heart disease.
Yep.
Because there was this lore in my family that her dad had passed from it. And so my mom was always terrified of heart disease.
Yeah. It is the number one, I mean, when we look at like, what are women afraid of?
Yeah.
Heart disease is not in the top two, right? I think the top 1 and 2 are breast cancer and dementia. But heart disease is the number one killer of women, right? Like we're afraid of the things that got publicity, right? We don't have pink can openers for heart disease.
I think that heart disease is partly a consequence of being human. I think that over a long enough time frame, everybody develops atherosclerosis, right?
Yeah.
I have a friend who's a PhD and he was an MD student, I think he's on hiatus with regards to his medical studies, but PhD, brilliant guy, Kevin Bass, he's been on the show. And he said, he brought to my attention the fact that when we became bipedal organisms, our blood pressure relative to other animals, even other great apes, skyrocketed. And that's what is required by our vasculature to pump.
To keep upright?
Yeah, to stay upright and
Interesting.
to, you know, and to pump blood from our toes all the way up to our brains. And so we have unusually high blood pressure.
Yeah.
Which is, of course,
It's a stress on the heart.
Yeah, is a stress on the heart. And hypertension, I mean, beyond what our normal blood pressure is, puts you at risk at even greater risk for atherosclerosis.
Totally. Again, going back to like what the haters say about hormones is like, they'll be like, we don't have that randomized placebo-controlled trial showing that it decreases the risk of heart disease. We have plenty of observational studies, right? Again, 40% of women were on this in the 90s. The cardiologists knew. But the haters will say, we don't have that gold standard study. And it's like, well, but let's use what we do have. Hormones decrease cholesterol levels. Hormones help you sleep better. Hormones decrease your blood pressure. Like all these markers of risk factors for heart disease, we know hormones help. So how does it not move the needle on heart disease? And do we actually need, I mean, that's the thing is like, can we use the data that we have to make as well of informed decisions as we can? Research is not happening right now. Right? So to be like, oh yeah, please hold your breath for another $1 billion randomized placebo-controlled trial is like, we can't. We need to use the data that we have. And that was the reason I wrote this book is like, people keep saying we need more data. We need more data. I'm like, I agree. Like I have tons of questions. We do not have. What's the ideal estrogen level to prevent dementia? Is it 30? Is it 60? Is it 120? We don't know. Right? So there's tons of questions we need to answer. But I wrote a book to be like, this is 300 pages of the data we do have. We have enough to make an educated decision if you want to be on hormones, if you choose to.
Yeah. How much do diet and lifestyle play a role in hormone balance, symptoms, progression, et cetera?
Well, they don't make menopause not happen, right? But smoking is literally like the worst thing for your ovaries. So we know that smokers go into menopause way earlier, but as far as everything else, we can't say it's going to extend the ovarian lifespan, but researchers are looking into that. They're like, what if in 20 years from now, they'll be like, remember when Kelly was talking about taking hormone replacement therapy? We don't have to do that anymore because we figured out how to make the ovary live longer, right? That would be sweet. And like PhD people are working on that. It's like, what if menopause is an option or like, you know, not a default? And so that's my last chapter is like, what if menopause gets to be optional at some point? But we're not there yet, so we have to use the hormones that we have. But smoking's horrible. And then as far as symptoms, exercise reduces hot flashes. Exercise helps you sleep better. Exercise helps preserve lean body mass, right? So it's not like, oh, just take hormones and then be sloppy with everything else. It's like, no, it's just part of the puzzle. And in my book, I'm like, hormones, yes, but like you got to lift weights. Alcohol's not a great idea. Like, it's not one thing of like, oh, I'm going to take hormones to prevent dementia, but then I'll slam a bottle of wine every day. Right? So it's like everything counts and it's not an either or. It's like all of the above. But for people, you know, you see this on the internet a lot of like, if you only just like master your fascia, you won't go into menopause. It's like, no, that person doesn't understand physiology, right? That's not how it works.
So interesting. Do the ovaries actually die, or they just stop working? They don't die.
They don't die.
Yeah.
Yeah.
It's not like necrotic tissue in your body, but they cease to do their thing.
Well, they're about the size of like a big walnut, right?
And in men, they become testes.
Yeah, they're testicles. And testicles are bigger. But here's the thing, is like if we continue our longevity journey, more and more men will probably outlive their testicle function. Right, but testicles don't have follicles in a sense that like a follicle is created to have an egg to release and that follicle makes hormones. And there's only so many follicles. So if you live enough years, you will run out of follicles, right? So it's a little bit different than a testicle. But it's like, you know, testosterone will go down as a man ages too. And if we start making it to 110, 120, like testicles might not last that long. We don't know. And will we give them testosterone when they run low? Yes, by and large, we give men testosterone when they run low.
That is so crazy to me. Yeah, I have my own like urology story.
Oh yeah.
Yeah.
Give it to me. I collect them.
You do? Oh, yeah. No, it was actually when I was so I guess 10 years ago now, if not more. There were on 2 occasions I woke up and I had testicular torsion.
Ooh.
Yeah, it was like the most painful experience of my life.
You guys puke.
Yeah, it was awful. I wasn't even doing anything fun. I literally had just woken up one day.
Yeah, that's when they just jump around in there. For your listeners who don't know, the testicle hangs on a cord, the spermatic cord, and that's with blood flow and the vas deferens where sperm goes through. And then you can twist, so it's like a bell, right, on a string, and it just twists. And it's like a heart attack, right? It's basically a testicle heart attack because you're just twisting off the blood supply, and that's the pain.
Crazy.
So if it doesn't flip back, you get surgery to untwist it and then sew it into place so it decreases the risk of twisting again.
Yeah, so that's what I had ultimately. I had an orchiopexy,
Yep.
which is normally performed on people that have undescended testicles. Mm-hmm. Mine were totally descended. They were totally, normal and healthy. But yeah, on 2 occasions. The first occasion, it kind of like fixed itself, like it untwisted. I like intuitively, I just like got on all fours and was like dangling them around, and like they
pro move.
Yeah, pro move. But then the second time didn't untwist.
Yep.
And I somehow was able to drive myself to the emergency room, which, by the way,
my God.
I didn't know that it was a medical emergency.
Yep.
It's not just an embarrassing thing.
No,
it's
we get to cut in line in the operating room when this happens. So we get to basically bump other surgeons to be like, we got a testicle that's torsed.
That's wild.
And then especially most surgeons are male. They're like, oh God, okay, no problem. Like,
and most of the time they require you to get it operated on there, right?
Ideally, we say time is testicle. So again, it's like a heart attack, right? The longer your heart goes without blood flow, the worse it is. And so if a testicle torses and it's been more than like 24 hours, the chance that you're going to be able to bring it back, like it's gone, right?
Damn, crazy. Yeah. So like the thinking was if I was traveling and like out of reach from an emergency room, like that would be a serious problem.
Right. Yeah. Nobody who listens to your podcast is ever going to do international travel now. Like, what if that happens on an airplane? It's very rare. Testicular torsion is very rare.
It was very scary. Yep. But the nurse who, she was not a nurse. She was the attending physician at the emergency room who untorsed me. She was actually really cute, and I ended up figuring out her email address. And
nice.
Yeah, we went out on a date. Which I don't know what
That's
lines.
the better part of your urology story.
Is it? Yeah.
Yeah.
That it was. It's a story I'll have with me for the rest of my life, and I'm very proud of it. But yeah, no, this is super, super interesting stuff. I think like the more awareness we can raise about this, the better. Are there still roadblocks? I mean, are the roadblocks more? Not enough people know about this. Not enough women know about this, or is there actually resistance from the medical establishment?
I don't think there's so much of a resistance as a lack of education, because after the WHI, hormones were bad. Nobody got trained. And what we're doing with this groundswell of like podcasts and Instagram and book writing and all this stuff is we're training the people on how your body works. I want you to know how your body works. I want you to know what the options are. And I want you to know how to talk to a doctor, right? So advocacy comes on top of this. And so they're going in and they're saying, hey, I need a vaginal estrogen. I'd like to consider testosterone, blah, blah, blah. And most doctors are like, oh my gosh, I had 5 women in this week all want to do this. I need to learn how to do this. So doctors are getting trained now more than ever. And the medical schools are picking it up and residencies are picking it up. So it's changing. And it's very exciting to be like, what does 10 years look like? What does 5 years from now look like? Because we've come a very long way in 3 years, right? So maybe there will be a day when we'll be like, hey, you're 45. Let's just have a conversation. Ovaries are doing their thing at some point. If you want to decrease your risk of disease, let's talk about it. So we're changing, like medicine's a big ship, right? Changing it top down, very difficult. JAMA published an article, good science research takes 17 years to get into the clinic room. So when, for example, for the Biden administration, they had their big like women's health research data. And I sat in on a Zoom and I'm like, if you don't provide translation to let the doctors know about this, you're going to do new research and it's going to sit behind a paywall. We have to get it out to the doctors so they know that things are safe and effective and what the data shows. So that's a problem. If a woman comes in and gets denied, she doesn't often know. You can get a second opinion. In America, you can get a second opinion. Often in Canada, you have the doctor you were assigned. Those women can't get second opinions. So in America, we have the freedom of giving. It takes more time, takes more money, but you can get a second opinion. So that's a roadblock. Insurance coverage is a roadblock. So when I went to the FDA and I spoke on female dose testosterone, I said, do not FDA approve this for libido. Because if you FDA approve this for libido, there's sex exclusion riders on insurance companies. They don't have to pay for anything that has to do with sex. Stupid rule, many people have sex, but insurance says that's extra. We're not going to cover it. So if you FDA approve this for libido, it'll get denied by insurance companies. I want it approved for the same thing men have it approved for, which is hypogonadism. So insurance coverage is a problem. FDA approval, I need it approved for the right thing so insurance can cover it. A lot of insurances will cover birth control, but not hormone replacement therapy. So a lot of women, they're like, hey, my birth control is free. How long can I stay on this, right? Because they're not going to cover my patch. So insurance coverage and that bias of like those hormones are okay to be covered, but these hormones aren't okay to be covered. So there's lots. I mean, in testosterone, God, the gender bias of like, people don't even know ovaries make it. And there was no FDA approval. And the DEA regulated it because of the Olympic doping scandals of the 80s, right? So there's an extra level of regulation to it, which we asked Dr. Marty McCary, like when you approve a female dose testosterone, do not have this DEA restricted. I cannot make you a gold medal pole jumper on female dose testosterone. Like it can't be done, right? It just increases the barriers to access to have it DEA restricted. So it's like, there's so many barriers, but women are smart. And like the data is profound, right? We know it in perimenopause, they did a randomized placebo-controlled trial. So people are asking for randomized placebo-controlled trials. We have them, let's use them. Perimenopause, prediabetes, randomized to placebo versus estrogen patch, followed for a year. 30% decreased risk of diabetes if you were pre-diabetic in 1 year after being on estrogen compared to placebo. Where's the Super Bowl ad? 30% decrease at risk of diabetes. Nobody's screaming about that study. Same thing, perimenopause, randomized placebo-controlled trial, patch versus placebo, risk of depression at 1 year. Because we know mood disorders and depression and anxiety skyrocket in perimenopause because of hormone changes. Significant decreased risk of depression at a year for the women who are on the estrogen patch. It's like, we've got the data. And that's why I'm like, I need to put this all in a book so I can just be like, it's here, we have this, let's use it. If we can prevent depression and prevent diabetes, not 100%, but it's better than placebo, why don't we know about this and why aren't we using these medications?
I'm so glad you put it all into a book. What's the diabetes connection? Is declining estrogen, does that have an impact on insulin sensitivity?
Yeah, so estrogen's anti-inflammatory, and when estrogen goes down, insulin resistance goes up.
Wow. Which increases your risk for a whole host
of heart disease.
Yeah.
Right? That's like, we can't prove it, hormones help heart disease. And it's like, but it helps all these metrics that increase the risk of heart disease. So like you put it all together and you're like, yeah, there's a mechanistic reason that you have less heart disease when you're on hormones.
Well, it reminds me of, sometimes people will get flagged for having high LDL cholesterol and they'll immediately go on a statin or start looking to their diet to cut out otherwise extremely healthy, but sources of saturated fat from their diet when, even mild hypothyroidism could be a cause of high LDL. And you might need to tend to your thyroid and look to nutrients that support your thyroid function. So it's just like everything is so interconnected.
It's all related.
It's all related. Yeah.
I mean, to me, I'm like, if you look at the hormone pathway, so hormones, testosterone and estrogen come from the cholesterol pathway. Starts with cholesterol, carbons get cleaved, you get testosterone, carbons get cleaved, you get estrogen, right? So I like to explain it like the body's smart. The body's trying to make what it had. Because otherwise you're like, why is your cholesterol going up? You didn't change your diet, you didn't do anything else, you're another year older, why is your cholesterol up? Like as your hormones go down, the cholesterol goes up to try to make more hormones. We have data, you put women on an estradiol, their cholesterol goes down. Not everyone. Right? But it's like it's not a mystery once you understand biochemistry and understand the pathway and be like, this is why it's happening. So great.
So great that we are shining a light on this crucially important topic. What else do you want people to know? I mean, obviously, I highly recommend anybody interested in this going through it should pick up your book. But is there anything I didn't ask you that you feel like is worth?
I mean, I would just say stop judging people for their decisions to be on hormones. I think so many women, they want to do it right. They want to do it the right way. And I think there's so much judgment on what people decide to do with their bodies in this realm of I see it all the time. It's like, I can't tell my sister I'm on hormones because she'll judge me. And it's like, can we just judge everybody a little bit less and be and self-advocate, right? I've done some research, I've listened to some things, and I'm trying to make the best decision so that I can play pickleball and be on the ground with my grandkids when I'm 74, right? Like there's value in choosing to try to maintain a healthy body. And I just see so much judgment still because of this damn WHI study of like, let women make smart decisions for their bodies and let's judge them less.
100%. Yeah, I don't understand why there's a stigma. I mean, I get like some of my male friends who are, not even yet in their 40s might be a little shy about revealing that they're on TRT. But if knowing that every woman goes through this and it's unavoidable, there's no perfect diet or lifestyle that's going to keep you from going through it, then why, who's judging? Like, I don't understand.
Yeah, it's stupid, right?
Yeah.
It's super stupid. I'm like, a hip fracture in your 70s and 80s is devastating and life-changing. And that's like 1 in 3 women will have a fracture. And if you have a hip fracture, death within a year for 30% of them. Like, and estrogen right now, with what we have, is FDA approved for the prevention of osteoporosis. We already have a prevention FDA approved option. If people, for the people who like hang on, like only if it's FDA approved, which doctors use things off label all the time. But people don't know, like this is FDA approved for prevention of fracture, for prevention of osteoporosis, right now. And so it's like, people don't know that how beneficial it is to keep your hormones, keeping your body healthy. And I think where we're going, like perimenopause is getting really hot right now. There's going to be a lot more books coming out about perimenopause. Your biggest risk of bone fracture is in the 2 years leading up to your period ending. Well, that's stupid. How do you know when your period's going to end, right? That's in the future. You have no idea. So you're telling me my bones are losing their maximum amount of bone density before my period ends? Yes. Okay. So isn't it better for me to try to prevent the bone loss instead of trying to make up for it once it's already gone? So I think treatment in perimenopause, and again, going to that Alzheimer's dementia paper, is like the earlier the better. Why wait to suffer? Why wait for it to go down? We're not there yet culturally, but I think, as a thought leader to be like, where are we going to be in 5 years with this? I think we're going to be treating a lot more people because Gen X is taking care of their moms. Gen X is seeing what frailty looks like. And Gen X is saying, if there's a different way to do this aging thing, we want to do it. So Gen X has really moved the menopause needle. And now the millennials are coming on our tail and they're like, hell no. We do not want to suffer, right? So they're going to take it, I think, another level than where Gen X has brought this. Yeah. And the boomers are pissed, basically. They're like, we were 51 when the WHI landed. We've been denied hormones. We're pissed now. So that's another population of like, we're probably going to start giving them more low-dose hormones because the fear of we might not be able to prevent dementia in you. We might not be able to prevent heart disease in you, but it will make your bones stronger. It will help you sleep better. And the risk of safe transdermal bioidentical is actually incredibly safe. So I think that's another underserved population that we're going to start treating more as people become more confident about the data that we have.
Wow, such important work. Well, Dr. Kelly Casperson, thanks for coming out.
Thanks for having me.
Yeah, I've got one last question for you, but before we get to that, where can people pick up your book? I know you've got this wonderful podcast that I had the privilege of being on. You're very active on social media. How can people find you and consume all the things?
Yeah, so website is kellykaspersonmd.com. First book about sex is called You Are Not Broken, if people want to go and learn about sex. Second one's about hormone and longevity. And so Amazon, Barnes & Noble, if you want to mom and pop and support your local bookstore, I've got a whole bunch of ones on my website. And then the podcast is called You Are Not Broken. Hang out on Instagram a lot at Kelly Casperson MD.
Love it. The last question that gets asked to everybody on the show, what does living a genius life mean to you?
Keep reading. Like if you read, especially about one topic, within a year, you'll know more than 90% of people on that topic. And I think people don't realize the power of continuing to read and continuing to learn.
I love that. My last guest that I recorded in here, we had wrapped up, and then as we were heading downstairs, they asked me, Max, what's your vision of a genius life? And I just on the spot, what came to mind was a sense of benevolent entitlement. And what I mean by that is entitlement is usually thought of as like a bad thing, but what about entitlement to knowledge? What about entitlement to success? Yeah. I think oftentimes we believe like, if I didn't have this sense of entitlement, despite because I didn't go through, the traditional channels of academia, of medicine, I might not feel entitled to the kind of knowledge that I currently have today that I use to improve my life and to improve the lives of my loved ones and everybody who listens to me. But because I had that sense of entitlement, I think Malcolm Gladwell talked about it a little bit in his book, Outliers. But yeah, for me, I feel like it's the sense of benevolent entitlement. And you reminded me of that because, yeah.
And I think the other thing, especially like for the doctor types, is like, so much. Help people with it. Like, and we help people, right? But it's like to help people on the stage that I can help people now because I'm able to communicate that knowledge is like, oh my God. Like I'll die now knowing that I've saved lives on a level that everybody hopes for, to be able to help people that much. So it's like, don't just keep it to yourself. Once you got it, don't keep it to yourself. Help humanity with that knowledge.
I completely agree. And it's kind of sad that social media can at times seem like such a toxic place.
Yeah.
Because it really is such an amazing tool
yeah.
to put your knowledge out there.
There was a study just published this year that said 80 to 90% of women get their healthcare knowledge on social media. And I think it's very threatening to the traditional academia because they think of themselves as maybe not the gatekeepers, but like the holders of the knowledge. And it's like, well, women are getting it over here. That's no good. And it's like, you have a 10-minute doctor visit these days. You do not have time to get educated in your doctor's office. Books are the solution. Podcasts are the solution. Social media is the solution. But be discerning,
yeah.
right? What credentials do they have? Are you hearing the same thing from other experts, right? Like, be discerning because not all of your knowledge should come from a 60-second Instagram reel.
Exactly. Well, you're the best. Thanks for coming out.
Thanks for having me.
Thank you guys for listening. Share this episode with people in your life that will benefit from it. And sending love. I appreciate you. I'll catch you on the next one. Peace.
Hey, if you liked that video, you need to check out this one here, and I'll see you there.